Just give me a minute, sir. I'll tell you when we can start.
Oh.
So we can start.
So I do my presentation now?
Yes, sir, please.
And so shall I do the whole presentation now?
Yes, sir. You can start with a welcome talk. If you want to welcome and greet everyone for a couple of minutes or half a second, and then you can start sharing your presentation and start the talk.
So this will take around 40 minutes.
Sure, no problem, sir.
Okay.
We are live.
So, hello everybody far away from Switzerland. This is my webinar that I would like to share with you in India. This is my webinar on the use of especially iron, but also intravenous iron in obstetrics. I have a long experience in Zurich with the use of iron preparations in pregnancy, and I would like to share with you some of my experience. There is a paradigm shift in the management, especially because there is a strong use now of intravenous iron preparations. Of course, there's also a standing of oral iron, but I will try to give you some more insights in when oral iron should be used or when intravenous iron should be used. So thank you for listening. So worldwide, there is a high incidence of anemia in women, especially in women of reproductive age. As you see here in the world, there is a prevalence of anemia between 20 and 40%. Independently where you live, you will always find a certain percentage of women who present anemia. And of course, there are also variations in prevalence that can reflect economic status and nutritional deficiencies. Now, we know that in the population, there are common causes of iron deficiency and anemia, such as decreased iron intake, especially for the increased number of vegetarians, or also women with otherwise unbalanced diet or eating disorders. There is in many cases decreased iron absorption, such in celiac disease or malabsorption or chronic inflammatory conditions. Many women face high blood loss due to heavy or prolonged menstrual bleedings, and then of course during deliveries and birth. And there is also conditions of increased iron demand, such as pregnancy and lactation, infancy, adolescence, or endurance sport. So all these factors contribute to iron deficiency, of course, and these factors can also summarize. So in many cases, we have combinations of all of these conditions. Especially pregnancy and pre and postpartum iron metabolism has a special demand on women's iron stores. As you see here, especially in the second and third trimester, there is an increasing iron requirement for the red cells, but also for the fetus and placenta. So around half of the iron is needed for the increase of red cell synthesis, and the other half is needed for fetus and placenta. That means that you have an almost 10-fold iron requirement in the third trimester, up to around 7.5 milligram per day, compared to the first trimester that corresponds to around 0.8 milligram per day. Now, since we know that the maximum absorption of iron in the body is around 3 to 5 milligram, there will be also a kind of deficit in the resorption. So this deficit has to be met by the maternal iron stores. If the maternal iron stores are empty, the increase of iron cannot be met by the maternal stores, and the mother will go to iron deficiency. Iron deficiency itself causes consequences for the fetus, such as low hemoglobin levels with an increased risk of spontaneous abortion, low birth weight or preterm delivery. Very low hemoglobin levels below 6 are associated with chronic placental insufficiency, and the low hematocrit is also associated with medical abnormalities, growth retardation, fetal death, and a premature rupture of fetal or amniotic membranes. In the pregnant woman, preconception iron deficiency can lead to chronic placental insufficiency, impaired physical performance, increased cardiac strain, and maternal death from heart failure and severe anemia, and also poor maternal thyroid status and wound healing is linked to poor iron status. So many endocrine and physical systems are linked to the iron metabolism. Now, if you see, if you would ask, what is the risk of anemia, or is anemia associated with a higher risk for perinatal outcome, then we know some studies like this study that was performed in Eastern Sudan, where you see here in the table, you see on the left side variables such as preeclampsia, eclampsia, preterm delivery, low birth weight, and stillbirth, and the odds ratio for mild and moderate anemia. And then you see the odds ratio in case of severe anemia. And what you see is for preeclampsia, eclampsia, preterm delivery, low birth weight, and stillbirth, the odds ratio increases between 3.6 up to 8-fold. So in severe anemia, all these risk factors are increasing dramatically. For example, the risk of low birth weight increases from 2.5 to 8-fold in severe anemia. So the greater the severity of anemia during pregnancy, the greater is the risk of preeclampsia, preterm delivery, low birth weight, and stillbirth. And preventive measures should be undertaken to decrease the prevalence of anemia in pregnancy. Interestingly, there's also an association between hemoglobin and neonatal outcome in preterm neonates. So in this study from France, there was an assessment of different hemoglobin levels of the mother. So what you see here is in the red line, that was for a hemoglobin below 10.7 in the mother. And what you see here is that the babies born to mothers with a hemoglobin below 10.7, for example, at 29 weeks, had a 3-fold odds ratio for a poor outcome, compared with mothers who had a hemoglobin between 10.8 and 12.5. So the red line shows you the difference and the link between maternal anemia and iron deficiency and the poor fetal outcome. As you see easily here, for up to 32 weeks, the babies born from anemic mothers have a poorer outcome. We also know that iron deficiency has long-term consequences of for the newborn child. So a high proportion of infants born to anemic mothers displays iron deficiency themselves. So in this study, you see on the left iron deficient infants with iron repeat mothers. It's only 6.5%, while this increases up to 40% in iron deficient infants with iron deficient mothers. So iron deficiency in the mother causes iron deficiency in the newborn and adolescent. And today we know that iron deficiency in the newborn and the adolescent child has a lot of impact, for example, on neurological, but also psychological and physical performance. In addition to iron deficiency, we know that there can be high blood loss in obstetrics. So both in pregnancy and in the peri and postpartum period, there can be chronic or acute bleeding events. There can be atonic bleeding due to coagulation problems, tissue lacerations, or vessel lacerations. All these causes are quite unpredictable. And if a mother is already anemic or iron deficient during pregnancy, the obstetrical blood loss can add to the pre-existing risks. So we will never know exactly if a woman gives vaginal birth or cesarean, or she shows increased bleeding or strong bleeding. So there might be a blood loss between several hundred milliliters, which is supposed to be normal. But the blood loss can also increase up to 500 to 1,000 milliliters, or even 1,500 milliliters or more. And if a woman is anemic prior to birth, and she will lose in strong bleedings up to 1 or 2 liters of blood, she's prone to be in shock or get blood transfusion. So we know that there's a fixed rate of blood transfusion. As you see here, the red line, there is a fixed rate of in this study 10 per 1,000 deliveries, and over the years the rate of administrating blood transfusion did not really increase, also because the measurements of anemia treatment are not very efficient in many places. And here you see that certainly anemia and blood transfusion has a link. So here we see the link between blood transfusion and cesarean delivery, and you see in the upper red line, you see the odds ratio for transfusion in mild anemia, which is a hematocrit between 25 and 29. So namely a hemoglobin around 9 to 10. You have an odds ratio to receive blood transfusion of 3.4. In severe anemia or a hematocrit below 25, which is a hemoglobin of 8, you have an increased risk of blood transfusion up to 17. So a 17-fold risk in cases of severe anemia for blood transfusion. Some mothers will refuse blood transfusion, such as due to religious issues or Jehovah's Witness. So in these cases, if a mother will refuse blood transfusion, it is mandatory to normalize her anemia before birth. We also know about transfusion complications. So all these complications that are summarized here can occur after blood transfusion, and we should avoid to have these complications in otherwise healthy women. And we can avoid these complications by normalizing anemia beforehand. So this leads me to the so-called 3 pillars of PBM, which is patient blood management in the gynecologic patient, which actually means to optimize the red cell mass before birth or surgery, to minimize the blood loss, and finally to optimize the physiological tolerance of anemia. These three pillars of patient blood management are the pillars of any surgical or obstetric patient. So if you remember the three pillars, then you can optimize the anemia management in your clinic, and you can reduce blood transfusion, which will increase patient survival and also positively influence patient morbidity. Just a few concepts for diagnostic issues. First of all, you should always have in mind the cutoff for hemoglobin in the pregnancy. So if you remember 11, 10.5, 11, then 11 in the first trimester is the lower cutoff for anemia. In the second trimester is a 10.5, and in the third trimester is 11 again. So 11, 10.5, 11 are the three cutoffs to remember. Any hemoglobin value below 10.5, any value below 10.5 in pregnancy can be considered real anemia. So any value below 10.5 is not physiologic anemia anymore. Just remember this. Also, you should remember some cutoff levels for iron parameters, especially for serum ferritin. So serum ferritin well below 15, in some laboratories also below 30 is defining iron deficiency. Again, remember the cutoff for hemoglobin plus ferritin. In some clinics, you have the opportunity to do additional parameters such as transferrin receptors or zinc protoporphyrin, but the main laboratory issue should be serum ferritin. Here again, you see in this ROC curve, you see that ferritin alone has the highest sensitivity and specificity to detect iron deficiency. There are other tests such as MCV, transferrin saturation, red cell distribution wide, and so on, but they are not neither that sensitive nor specific. So ferritin alone as a standalone test is a very good test. You should only remember that ferritin is also an acute phase reactant. That means in cases of inflammation or liver disease, the ferritin values will increase and will show false normal values. That means even in an iron deficient woman, if she has a inflammation or a viral cold or liver disease, her ferritin will be false normal despite iron deficiency. Just remember that. So if you suspect infection or inflammation, you have to reassess the ferritin values. This is a good example how ferritin acts as an acute phase reactant, because here in the upper picture you see the course of ferritin in a patient before and after cesarean. So 1 and 2 weeks after cesarean, the patient shows highly normal ferritin values up to 1,000. In the lower picture, CRP after cesarean, you see the same patient with this C-reactive protein levels, and you see easily that the ferritin follows the course of the C-reactive protein. So in that case, the ferritin reflects the inflammatory process of the cesarean, but not iron stores. So this leads me, after diagnostic, leads me to the therapy of iron deficiency. First of all, the mainstay of iron supplementation is oral iron. So here in Switzerland, we have various preparations such as iron 2 salts, like ferrous sulfates, fumarates, and glycine sulfate. We have iron 3 complexes, which are a combination between sugar and iron, and we have elemental iron, but this is quite new, and I don't have personal experience with elemental iron yet. The WHO guidelines recommend daily oral iron and folic acid supplementation as a part of antenatal care to reduce the risk of low birth weight, maternal anemia, and iron deficiency. So, in case of iron deficiency, and you can always try and use daily iron and folic acid as a first day of therapy. But in severe cases, and I will show you later, you might switch to intravenous iron. The dosage schedules to prevent iron deficiency are for women of childbearing age and anemia, the prevalence over 40%. It is recommended to give around 60 milligram per day for 3 months. In pregnant women, it is recommended to give 60 milligram per day as soon as possible gestation starts. And in the postpartum period, also in the prevalence of high anemia, you should give oral iron up to 3 months postpartum. The problem is for oral iron that the resorption on the gastrointestinal side can be inhibited. So many women that take oral iron have a problem in the resorption or with side effects of oral iron. So in this slide, you see that with increasing dosages of iron, you have an increasing number of side effects, such as constipation in blue, diarrhea in green, heartburn, and nausea in red. So the more iron you give, the more side effects you will have, and the less will be the compliance of the patient. 1 over 5 women will stop oral iron tablets. This is an interesting study that compares the side effects and discontinuation rates for various preparations. So on the left, you see the preparations, and on the far right side, you see how many percentage of patients discontinued the iron intake. And you see that overall around close to 20% of the patients will discontinue oral iron administration. That means every 5th patient will stop the medication due to these side effects. If you have a patient with side effects on on oral iron sulfate, for example, here you see in gray, FS is iron sulfate. You might switch to a preparation that contains iron polymaltose in orange, and you see that the side effects in orange with polymaltose are less than in iron sulfate. Mostly, so in some patients it might be worthwhile to switch from iron 2 complexes to iron 3 complexes to reduce side effects. Another problem in the resorption of iron is the so-called iron regulating hormone hepcidin, which is released from the liver. High hepcidin levels are reducing the resorption of iron, and especially in cases of cytokine release and inflammation, you have an increase of hepcidin levels and a decrease of iron resorption. That means that in inflammatory states or after surgery, the iron resorption is very low, and therefore anemia treatment in this case is difficult. Remember that what I showed you before, that the C-reactive protein is increasing after cesarean delivery. And since the C-reactive protein is increasing, you have a high response of inflammation, and less iron will be resolved. So, as we said already now, the treatments of iron deficiency in pregnancy are all oral iron, which is has a relatively low cost, and it's suitable for almost all women. But compliance issues can be associated with gastrointestinal adverse events and oxidative stress. Blood transfusion can be life-saving in acute conditions, but involves a variety of inherent risks and complications, high cost, shortage in supply, and administrative errors. So therefore, in the middle, we have a third option, which is the intravenous iron, which is a very strong and important alternative. And I will now tell you something about intravenous iron. The intravenous iron preparations are mostly iron-3 complexes. They are iron-3 carbohydrate complexes like ferric carboxymaltose, iron isomaltoside, iron dextran, ferrum oxytol, and most famous also the iron sucrose, which is here is called Venofer. The nice thing in intravenous iron is that, as you see here on this experiment with radioactive intravenous iron performed in non-pregnant study persons, what you see here in black, in the black curve, is the increase of intravenous iron in the bone marrow. Namely, you see that already after 25 to 30 minutes, the black line, the bone marrow, the iron is incorporated in the bone marrow, while the quantity in liver, spleen, and blood is decreasing. So, and the incorporation in the bone marrow keeps over around 500 minutes. So over hours, the intravenous iron is incorporated in the bone marrow. So we have studied already in 1995, many years ago. We did the first studies using parental iron in pregnancy. So there's a long stay of experience, and then in the last years, more and more studies were comparing intravenous iron versus oral iron for treatment of anemia in pregnancy. This is a study from 2005, where you see on the left the increase from baseline after intravenous iron in black. Black boxes, and compared to oral iron, and you see that until the delivery, the increase of after intravenous iron sucrose is much better than with oral iron. Also, if you look for the ferritin values, you will see that 2, 4, and 4 weeks after start of therapy and after delivery, iron stores are higher using intravenous iron sucrose. This is another study from 1996, where you see that the time to maximum Hb level is shorter with original iron sucrose complex compared to ferrous sulfate. So here in red, you see the time from a baseline hemoglobin between 7 and 8 to normalize is around 6.6 weeks compared to 9 to 9.4 weeks in the control group. So by using intravenous iron, you can considerably shorten the time until normalization. This is another prospective randomized trial using iron sucrose and compared to oral iron. So here you see on the right side favors IV iron plus oral iron, and the left side favors oral iron. And what you see is on the side of the intravenous iron, the hemoglobin weeks, 4 weeks until delivery, ferritin, serum iron, and iron saturation are always in favor of intravenous iron. So the authors conclude that current guidelines should include intravenous iron. So the parental iron preparations used in pregnancy are, for now, iron carboxymaltose, which is called Farinject in Europe and Injectafer in the US. Iron sucrose, Venofer, which is probably for now the substance with one of the most experiences. Then we have some experience with iron gluconates, and then with the low molecular weight iron dextran, and the high molecular weight iron dextran should be avoided because they are they are causing a high rate of anaphylaxis and allergy. So high molecular weight iron dextran should be avoided if ever possible. The characteristics of iron carboxymaltose is that you can use high single doses up to 1000 milligram and use in the rapid administration as a bolus or infusion. And it has a very low immunogenic potential. That means that no free dextran is delivered in the bloodstream. If you compare the maximum dose and the fastest time en route, you see that for iron carboxymaltose, you are allowed to give up to 1000 milligram per single dose. Iron sucrose, you can give up to 200 milligram. The infusion time for carboxymaltose is 15 minutes, while it's around 10 to 30 minutes for iron sucrose. So iron sucrose and carboxymaltose, for our experience, are have a quite reasonable dosage in a short time. Some more results to carboxymaltose in pregnancy. Here you see. Here you compare the adverse events of iron carboxymaltose with iron sucrose, and you see that the local adverse events in iron sucrose and carboxymaltose are about the same. You have a little bit less systemic and total adverse events for carboxymaltose compared to iron sucrose, but both preparations are very safe and effective. If you look for the hemoglobin values, you see for both carboxymaltose and iron sucrose, you see normalization of anemia in both groups, and there is no statistical difference between carboxymaltose and iron sucrose. This is a prospective study in anemia in pregnancy on 65 patients who got around 1000 milligram of total dose of carboxymaltose. And you see 3, 6, and 8 weeks after infusion, the hemoglobin levels are considerably higher compared to before therapy. So you see these patients were treated between 34 and 36 weeks of gestation. The pre-infusion hemoglobin was between 8.3 and 10.2. and 6 weeks after infusion, all 3 groups, like severe, moderate, and mild anemia, had normalized their values. So it shows that there is a safe and effective use of carboxymaltose in the treatment of iron deficiency anemia in pregnancy. In 2017, we have released a randomized study on various places in Europe. This was a randomized study between iron carboxymaltose and all iron over 12 weeks. So we were comparing the administration of 1 to 1.5 gram of carboxymaltose with the oral iron. In the groups, there were around 123 and 124 patients. The baseline hemoglobin level was below 10 in both groups, and the baseline ferritin level was around 12, so iron deficiency anemia in both groups. Here in the upper curve, you see the increase of intravenous iron in red and oral iron in black. This is a non-inferiority study. So the change in hemoglobin levels in both groups were comparable. There was a slight better tendency for intravenous iron. Remember that intravenous iron was given only once to twice, while oral iron was given over 12 weeks. In the lower curve, you see the change in ferritin levels. In red, you see definitely higher ferritin and iron levels for the iron carboxymaltose group compared to the oral iron in black. Interestingly, here we found also positive issues for so-called vitality score and vitality score and social functioning. What you see here is after week 3 and prior to delivery, you see a significant positive change after intravenous iron for vitality score and social functioning. That means that giving intravenous iron is improving neurologic and psychological issues in pregnant women. The total adverse effects were comparable in both groups. So in the carboxymaltose group, it was 60 patients compared to 50 patients in oral iron. So there was no difference in adverse events in carboxymaltose versus oral iron, and no negative impact on the newborn. Also in the postpartum period, iron carboxymaltose can be used. This was a study that was published in 2008 from my research group. This is also a non-inferiority study to oral iron, and you see that that over 12 weeks, the effect of carboxymaltose is comparable with the administration of giving oral iron for 12 weeks. While iron carboxymaltose was given only once at baseline, 1 gram. This is the same study and the ferritin response, which was definitely greater in the iron carboxymaltose compared to oral iron. After 12 weeks, you see still higher ferritin levels in the intravenous iron group. This study was also performed with intravenous iron, and here you see in the postpartum the difference between giving intravenous iron to oral iron. So after 2 weeks, 4 weeks, and 6 weeks, the intravenous iron group is increasing much better. These are patients achieving hemoglobin over 12 and having an increase over 3 grams per deciliter after administration of intravenous iron. And also here you see easily in red that intravenous iron is superior in treating postpartum anemia. So in all relevant parameters, intravenous iron was found to be superior to oral iron, and the authors conclude that intravenous iron was safe and well tolerated. Now, in Europe, but also in Asia Pacific area, and according to recommendations of NATA, NATA is the network on advancement on transfusion alternatives. Intravenous iron is incorporated in the treatment regimen. So in different countries, there are different cutoffs when to use intravenous iron, but all countries here and in Asia Pacific include intravenous iron in the regimen. The same for pregnancy. Switzerland, Germany, Asia Pacific, the NATA and the United Kingdom are including intravenous iron in the recommendations for anemia treatment in pregnancy. Again, the international approach for iron deficiency anemia in Europe, such as United Kingdom, Germany, Switzerland, Scandinavia, Spain, and Eastern Europe, favors IV iron in anemia and risk patients. In Asia, in many countries, also like Pakistan, India, Malaysia, Singapore, Indonesia, China, and Thailand, favors intravenous iron in anemia. In the United States, we have no clear statements yet for intravenous iron, but in Latin America, the guidelines are in favor of intravenous iron. In Australia, the patient blood management favors intravenous iron, and we have no clear data for the African continent. So to conclude, first, an unfavorable iron status prior to pregnancy and changing iron needs require proactive assessment and management of iron status in pregnant women. In cases of mild anemia and sufficient available time, oral iron can improve hemoglobin levels before delivery. You must consider different side effects of different iron compounds. Intravenous iron normalizes hemoglobin levels more rapidly and in more patients than oral iron preparations. Established treatment recommendations for anemia in pregnant women should be taken into consideration. So I thank you for your attention. I hope I could add something to with this webinar to the success of iron and anemia treatment in your clinic and your place. And in any case, if there will be more questions or queries, please don't hesitate to contact me anytime. All the best to you, and stay healthy. Thank you very much. Bye-bye.
So Pranav, is it okay?
Hello?
Yeah. So thank you, Professor Bremen. Thank you very much for your wonderful session. I just wanted to ask my